Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. And as you are aware, all our lectures are available on YouTube, which is freely downloadable and you can see them at your leisure time. We also have a Telegram group which you can join, and from there you can get all the lecture related information. Then we have the Google Drive where all the PDF of the lectures are available, and we have the master integration key by which you can navigate between the Google Drive and the PDF. These are the disclaimers. And we are with phase 3, which is recorded pathology lectures, which is convenient for the teachers, the students, as well as for the organizers. And today we have Pursue 19C, which is hematology, hemostasis, and thrombosis. And we are streaming live from AIIMS Kalyani. And today's topic is classification, clinical manifestation, and evaluation of disorders of hemostasis, which is very basic, fundamental, but very essential. And to talk on today's topic, we have Dr. Sujaya Mazumder. She's an MBBS, MD, DNB, PDCC in Hematology from JIPMER, Puducherry. Presently, she's an assistant professor in the Department of Pathology and Lab Medicine, AIIMS Kalyani, West Bengal. She's also been the senior resident at JIPMER and Bhaba Atomic Research Center Hospital. Her areas of interest being leukemia, flow cytometry, coagulation disorders, and lymphoma. She's got multiple publications in various national and international journals. Was awarded the gold medal for the best outgoing intern in the batch 2013. I would request Dr. Sujaya Mazumder to start her lecture, ma'am, please.
A very good evening to all of you. So the topic that I will be discussing today is classification, clinical manifestation, and evaluation of disorders of hemostasis. I'll be giving you an overview as to how to approach a case of bleeding disorder. So to begin with, what is hemostasis? Now, hemostasis is a process of forming clot at the site of injury. It encompasses the tightly regulated process of blood clotting, platelet activation, and vascular repair. So basically, it is a teamwork between the platelets, the vascular endothelium, the coagulation system, and the fibrinolytic system. So before we go into the pathological aspects, let us just relearn or revise what is normal. So these are the components of hemostasis. The first thing is primary hemostasis, which consists of the blood vessels, that is the vasoconstriction by the blood vessels, platelet activation, and formation of the primary platelet plug. Whereas the secondary hemostasis comprises of the coagulation cascade, which culminates in formation of thrombin, which converts fibrinogen to fibrin and forms a secondary platelet plug or the blood clot. After which comes the role of the plasmin, which causes fibrinolysis and clot degradation. So primary hemostasis is short-lived and initiated within seconds. It starts off with local vasoconstriction, and platelet is the key cell in primary hemostasis. And there are 3 steps to platelet, that is your platelet adhesion, activation, and aggregation. So the first step, as we just mentioned, is vasoconstriction. Now, arteriolar vasoconstriction occurs immediately and markedly reduces blood flow to the injured area. It is mediated by reflex neurogenic mechanisms and may be augmented by the local secretion of factors such as endothelin, which is a potent endothelium-derived vasoconstrictor. This effect is transient and bleeding would resume if not for activation of platelets and coagulation factors. So the next thing that happens is your primary hemostasis, which is the formation of the platelet plug. Now, disruption of the endothelium exposes the subendothelial von Willebrand factor and collagen, which promote platelet adherence. That is your first step, which is your platelet adhesion. And then comes the platelet activation. Now, activation of the platelet causes a dramatic shape change. That is, from the small rounded disc that the platelets are, they actually become flat plates with spiky protrusions that markedly increase the surface area, as well as the release of secretory granules. So ADP, thromboxane A2, these are all granules that are released from the platelet. And within a few minutes, it recruits further platelets, that is, additional platelet recruitment occurs, and aggregation occurs and formation of the primary hemostatic plug. So a little bit about the platelet structure, right? The function depends on several glycoprotein receptors that are present on the membrane. It has a contractile cytoskeleton which helps in the shape change, and there are two types of cytoplasmic granules, that is the dense granules and the alpha granules. Platelet adhesion, which we saw was the first step in your formation of the primary platelet plug, is mediated largely by interaction of the von Willebrand factor with the von Willebrand factor receptor, which is your glycoprotein 1b, right, and collagen with the collagen receptor, which is GP1A 2A. Platelet activation is actually secretion or release reaction of the granule contents that occur along with the change in shape. These two together are called as platelet activation. So activation is triggered by a number of factors, like for instance ADP and thrombin. Now thrombin, how does thrombin activate the platelet? It is by binding to these G protein coupled receptors, which are the PAR receptors, which is switched on by a proteolytic cleavage that is carried out by thrombin. And ADP is a component of the dense granules, and thus platelet activation and ADP release, it actually begets other platelets or calls in other platelets to the site, and that is a phenomenon called as recruitment. So in a platelet there are several platelet agonists which help in platelet activation, like collagen, thromboxane, ADP and thrombin, and the dense granules and the alpha granules actually contain these platelet agonists. Next is a step, that is your platelet aggregation, which follows platelet activation. The conformational change in glycoprotein 2B1A, this 2B1A receptor, occurs with platelet activation and allows the binding of fibrinogen, a large bivalent plasma polypeptide that forms bridges between the adjacent platelets, leading to the aggregation. The aggregation is mediated by platelet receptors, platelet-derived agonists, platelet-derived adhesion proteins, and plasma-derived adhesion proteins. That was primary hemostasis. Now secondary hemostasis starts off with a cascade of coagulation serine proteases leading to generation of thrombin. It culminates with thrombin causing cleavage of the soluble fibrinogen to insoluble fibrin, forming a cross-linked fibrin mesh at the site of injury. It occurs simultaneously with platelet aggregation, and it is stabilized by the cross-linking activity of factor 13. So the coagulation cascade is a series of amplifying enzymatic reaction that leads to the deposition finally of the insoluble fibrin clot. So you already know this part where the coagulation cascade is divided into the extrinsic pathway and the intrinsic pathway. The extrinsic pathway essentially is activated by tissue factor and essentially composes of factor 7, and the intrinsic pathway or the contact activation pathway is actually started off by factor 12, and there is a role of 11, 9 and 8, and both of this culminate to the common pathway, which is your factor 10, which converts prothrombin to thrombin, which converts fibrinogen to fibrin, and in the presence of factor 13, a cross-linked fibrin clot is formed. And there are a lot of inhibitors, natural inhibitors of the coagulation cascade, like your antithrombin, tissue factor protein inhibitor, activated protein C, protein S, etc. So that was your cascade model, and the new model that is proposed is the cell-based model, which is divided into the initiation, which is mainly the tissue factor based process. Then comes the amplification by the platelets. Then comes the propagation by the activated platelets. Finally comes the stabilization of the clot and inhibition of the further coagulation. This is the cell-based model in comparison to the cascade model that we saw in the previous slide. Special mention to the von Willebrand factor, which has two main roles. One is it mediates adhesion at the site of injury that we just saw with the help of GP1B receptor. The platelet adheres to the site of injury with the help of von Willebrand factor. And another important role is stabilization of factor VIII in circulation. So this is important to remember because a von Willebrand factor defect can affect both the primary as well as the secondary hemostasis. Now coming on to the classification of the disorders of hemostasis, it becomes easy to compartmentalize them into a vascular disorder, platelet disorder, coagulation disorder, and a mixed disorder which has probably the role of all of the compartments. So the vascular disorders examples would be scurvy, easy bruising, or henoxia in purpura. Examples of platelet disorder could be divided further into quantitative and qualitative defect. That is, quantitative would be thrombocytopenia, qualitative would be platelet function defects. And congenital coagulation disorder can be divided into congenital and acquired disorder. Congenital would be factor deficiencies, most commonly hemophilia, that is factor VIII deficiency, that is hemophilia A, hemophilia B being factor IX deficiency, and the von Willebrand factor deficiency causing the von Willebrand disease. Acquired defects could be vitamin K deficiency, liver disease, and a mixed scenario is most often DIC or disseminated intravascular coagulation. So just a flow chart to highlight the same. You could divide a bleeding disorder into hematological and non-hematological causes. Non-hematological causes would be the vascular causes. Hematological causes would be platelet or factor abnormalities. Platelet can again be divided into quantitative and qualitative. Quantitative being the number of platelets reduced because of increased consumption, decreased production, or sequestration, and qualitative being a effect in the function of the platelet by itself. Factor abnormalities can be defect in the factor or presence of inhibitors which affect the factors. Coming to the disorders of the vascular system can be divided into inherited disorders and acquired disorders. Now, inherited disorders could be, examples would be hereditary hemorrhagic telangiectasia, Ehlers-Danlos, Marfan syndrome, osteogenesis imperfecta, all of which, in all of this, the basement membrane or the collagen itself is defective. Whereas the acquired disorders could be some such as scurvy, which is vitamin C deficiency, Cushing syndrome, amyloidosis, infections, drugs, to name a few. So the vascular disorders of hemostasis are those where there is a defect or deficiency in the vessel wall by itself. In general, the tests of coagulation available in the lab will be of little help in elucidating such defects. Hemorrhagic diathesis due to platelet disorders can be of two types, quantitative and qualitative disorder. Quantitative being decrease in platelet number or thrombocytopenia, and qualitative being defect in platelet function. Now we'll be looking at the quantitative defects or thrombocytopenia. Now thrombocytopenia is traditionally a platelet count less than 1.5 lakhs. However, a platelet count of less than 1 lakh may be actually a more appropriate definition for thrombocytopenia. Further classifying thrombocytopenia into mild, moderate and severe, a platelet count between 75,000 to 1 lakh is mild thrombocytopenia, between 30 and 75,000 is moderate thrombocytopenia, and anything less than 30,000 is severe thrombocytopenia. The causes of thrombocytopenia can be divided into failure of platelet production, increased consumption, abnormal distribution of platelets, and a dilutional loss, like how that would be seen in a massive blood transfusion. Failure of platelet production can be a defect in the megakaryocyte by itself, like congenital defects like congenital megakaryocytic thrombocytopenia, or it could be a part of a general bone marrow failure where even the other cell lines may be reduced, like aplastic anemia, radiotherapy, leukemia, MDS, myelofibrosis, multiple myeloma, megaloblastic anemia, HIV infection. Increased consumption can be Immune, like autoimmune or alloimmune. Autoimmune conditions like ITP, SLE, CLL are some. Alloimmune can be post-transfusional or fetal-maternal alloimmune thrombocytopenia. DIC and TTP are other causes where there is increased consumption of platelets. Abnormal distribution happens in liver disease where there is a massive spleen which traps in the platelets. Moving on to hemorrhagic diastasis due to platelet qualitative defects. So we just saw quantitative. Moving on to the qualitative defects. What are the causes? So platelet function defect inherent causes are can be divided into disorders of adhesion, that is defect in the platelet to vessel wall interaction. So we had just seen that the von Willebrand factor and GP1B9 helps in platelet adhesion. So if there is a defect in the von Willebrand factor or if there is a defect in GP1B9 which is called as the Burnett-Sodich syndrome, or if there is a defect in the collagen receptors which we also saw helps in adhesion, that is your GP1A, 2A receptor, would all lead to platelet function defects, adhesion defect. Disorders in aggregation. Now we had seen that for aggregation to occur, the receptor is GP2B3A with the help of fibrinogen. So if there is a fibrinogen defect or if there is a GP2B3A defect, both of which can cause a platelet aggregation defect. The further defects could be defect in the alpha granule, defect in the dense granule, which can cause to storage pool deficiencies, gray platelet syndrome, and there could be further defects in the receptors like your thromboxane receptor, ADP receptor, collagen receptor. It could be in the G protein activation, it could be in the phosphatidylmethylmalonic metabolism, etc. And the acquired platelet defects causes, some are uremia, drugs like aspirin, alcohol, myelodysplastic syndromes, AMLs. They all formed functionally. They all have a defect in the stem cells itself, which can form functionally abnormal platelets. Similarly, in myeloproliferative neoplasms like CMLs, polycythemia vera, ET is one cause, essential thrombocytosis is one cause where platelets, megakaryocytes are produced, but they all tend to, they are all abnormal and tend to produce abnormal platelets in terms of platelet function. And even liver disease is another cause. So that was platelets. Then coming on to the coagulation disorders, again can be divided into hereditary or acquired. They can be defect in any of the coagulation factors, factor 2, 5, 7, 8 and 9 are most common, 8 being the most common. What's that? 10, 11 could be factor 13, could be combined defects like factor 5 with factor 8 is one such combination, and one will be factor deficiency. Next is, this is to just show you the the inheritance pattern. Like for instance, hemophilia has an excellent recessive trait. Most of the factor deficiencies have an autosomal recessive trait, whereas von Willebrand can have an autosomal dominant trait. Then we move on to the coagulation disorders, the acquired type. There could be a deficiency of vitamin K dependent factors like in neonates, malabsorption, heavy antibiotics, coumarin defect, therapy, liver disorders, heparin therapy, circulating anticoagulant like your lupus anticoagulants, and disseminated intravascular coagulation being some of the acquired conditions of coagulation defect. Von Willebrand disease is another disease which requires special mention, where there is a quantitative or qualitative defect of von Willebrand factor that is again divided into type 1, type 2 and type 3, where type 1 and 3 are quantitative defect, 1 being partial deficiency of von Willebrand factor, 3 being complete absence of von Willebrand factor, whereas type 2 is a qualitative defect where either the multimer is defective or the site of binding with factor 8 is defective, all of which leads to bleeding disorders. Now, how do I approach a case of bleeding disorder? First, to suspect, next is a good clinical history and a good clinical examination, followed by screening tests, followed by specific tests which are based on the screening test and the history and the clinical examination, which would finally lead us to the specific diagnosis. So the first thing is to determine that now this patient has a bleeding disorder. So the patient should have a spontaneous bleed and an abnormal bleed. Now my neighbor's child often complains of nose bleeding. On further probing history, she picks her nose. So that is traumatic bleeding, that is not spontaneous bleeding. So you cannot call that a bleeding disorder. So it has to be a spontaneous bleeding and it has to be abnormal. For instance, even if it's not spontaneous, like if surgery will obviously cause bleeding, but is it a prolonged bleeding? Is it abnormal? So it has to be spontaneous or abnormal bleeding or both. So that is the first thing, is to ascertain and to suspect that this patient probably has a bleeding disorder. Now, is it a qualitative defect or is it a quantitative defect? For instance, platelets. Is it that the platelet count itself is low? Or is it that the platelet that is produced has some functional defect because of which, though the count is normal, it is not able to form a primary plug? So is it quantitative or is it qualitative? So the next thing is it hereditary or is it acquired? So the age of onset, the duration of symptoms help us in determining whether it is a hereditary disorder or an acquired disorder. Now in generally, coagulation defects are usually hereditary and platelet defects are usually acquired. So the next thing to determine is it a primary defect or a secondary defect? Are we talking platelets or are we talking coagulation? So the cornerstone to investigation of a bleeding patient is a good history and a clinical examination. Now, there are certain structured bleeding assessment tools like the ISTH batch score, which is developed by the International Society for Thrombosis and Hemostasis. These screening tools can be used to screen bleeding patients. The ISTH batch comprises 14 categories for assessing bleeding symptoms. A high bleeding score is associated with an inherent bleeding disorder. And these 14 parameters are basically based on the history and the clinical examination of the patient. So the history gives us certain clues like the need for transfusion and the number of transfusions administered, detailed inquiry about past injuries and operations, whether there was any prolonged bleeding after injury or after surgery, whether there was any prolonged bleeding after tooth extraction, is the patient on any drugs, any medical history like liver disease or renal disease, the age of onset and the duration of symptoms, like is it a hereditary, helps us to determine is it a hereditary condition or an acquired condition. And family history again becomes a very important uh, history that is to be elicited, the history of consanguinity, and a pedigree analysis helps to determine which bleeding disorder are we dealing with. For instance, an X-linked recessive trait would indicate a hemophilia. Now, menorrhagia is one of the most common symptoms which women with bleeding disorders experience. There are certain scoring systems to use for menorrhagia. The PBAC scoring system is one of the most commonly used scoring systems. The type and the sites of bleeding can give a clue towards the disorder of primary versus secondary hemostasis. So if we are seeing superficial mucocutaneous bleeds, like nose bleeds or gingival bleed, abnormal menstrual bleeding, skin bleeding, then we must suspect a primary hemostatic defect like a platelet disorder or a mild von Willebrand disease. If we are experiencing deep parenchymal bleed, like joint bleed, muscle bleeding, other internal bleeding like brain or retroperitoneal renal bleeding, then we should think coagulation. So superficial bleeds give a clue towards a primary hemostasis like epistaxis, gum bleeds, and skin bleeds being petechiae, purpura, and ecchymosis. So what is a petechiae? Petechiae is tiny skin bleeds of 1 to 2 millimeter size. Purpura is of more than 3 millimeter, however less than 1 centimeter, and ecchymosis is more than 1 to 2 centimeters, so a large patch. So these are all certain clues towards primary hemostasis. Now deep bleeds are a clue towards the secondary hemostasis, like hematology, CNS bleeds, hematuria, hematemesis, melena, recurrent GI bleeds. They are all clues towards secondary hemostasis. So just to highlight the clinical differences between the platelet disorders and the disorders of coagulation, petechiae, superficial bleeds, superficial ecchymosis are all characteristics of platelet disorder, whereas deep dissecting hematomas, hematolosis, delayed bleeding are all characteristics of coagulation disorders. Platelet disorders are more common in females, whereas most of the coagulation disorders, at least 80 to 90%, are inherent forms in males because of the X-linked inheritance. And positive family history is more common in defects of the coagulation system. So moving on to the next aspect after a good history and clinical feature is the screening tests. So no single test is suitable for laboratory evaluation of the overall process of hemostasis. Several methods of varying principles and use are available for assessing the various components and functions. So the screening tests of hemostasis, if I want to divide it into primary and secondary hemostasis, bleeding time, PFA 100, which has now replaced bleeding time, platelet count and blood smear are the tests for primary hemostasis, whereas a clotting time, which is again now a crude test which is no more done, a PT and APTT, a TT and fibrinogen, that is your prothrombin time, activated partial thromboplastin time, thrombin time and fibrinogen are tests of secondary hemostasis. Now if I combine it all, and what we do generally in the lab is a screening coagulogram, which constitutes of a platelet count, that is a CBC with a peripheral smear is often advisable, prothrombin time, and activated partial thromboplastin time, that is APTT, your thrombin time, that is your TT, and your fibrinogen. Now these five tests form the screening coagulogram, and the permutations and it's almost like, sometimes I'd like to say that coagulation study is almost like mathematics. So the permutations and combinations of these tests actually further guide you towards the further tests that could be done and towards the disease that we're talking about. And in fact, a good history and a good screening coagulogram will prevent doing unnecessary expensive tests on the patients. So discussing a little bit about each of these tests, the first being the prothrombin time with INR. So a PT value is never reported alone, it is always reported along with the INR. Now prothrombin time is the time in seconds to form the fibrin clot and is a measure of the extrinsic and the common pathogens. So while doing a PT test, you require calcium and thromboplastin. Now once platelet plasma is taken and thromboplastin is added, and it is incubated, after which calcium is added and the clotting time is recorded. A normal prothrombin time is 11 to 14 seconds. Your INR. Your INR is your international normalized ratio, which is a way of standardizing the PT no matter what reagent is used. In the sense, to make it uniform across all the thromboplastin reagents that is used, INR is a better form of reporting. INR is nothing but PT ratio to the power ISI of the tissue thromboplastin that is used. Its normal range is 1 to 1.2. What is ISI? ISI is International Sensitivity Index, and it is a specific for each lot of thromboplastin reagent, and it's actually given by the manufacturer. So our ISI that is close to 1 is the best thromboplastin. PT ratio is nothing but PT of test divided by the PT of the control. So PT test by control to the power of ISI will actually give you your INR. And this INR is used to monitor anticoagulant therapy like warfarin. Next is the activated partial thromboplastin time. It's called partial thromboplastin because there is addition of phospholipid here but without the tissue factor. So here platelet poor plasma is taken and there is a clot activator like your kaolin or your silica which is added, and phospholipids are added. It is incubated, after which calcium is added, and once calcium is added the clotting time is recorded. It is the time taken for the fibrin clot to form, and it measures the function of the contact activation of the intrinsic pathway and the common pathway. So PT, what we saw was extrinsic pathway and common pathway. APTT is intrinsic pathway and common pathway, and the normal time is 26 to 40 seconds. Next is the thrombin time, which is the time taken for the thrombin to convert fibrinogen to insoluble fibrin. To platelet poor plasma, thrombin reagent is added and the clotting time is recorded. The normal time is 15 to 19 seconds. A prolonged TT indicates a fibrinogen abnormality or an impairment of the fibrin formation or thrombin inhibitory effect. Now that is done by drugs like heparin. So heparin contamination, mind you, is one of the most common causes of and prolonged TT. So where an APTT and a TT is prolonged, the first thing that we have to consider or rule out is a heparin contamination. So to summarize, so far APTT measures the intrinsic pathway and the common pathway. PT measures the extrinsic pathway and the common pathway. And TT is the time that is taken to convert fibrinogen to fibrin. The next test is fibrinogen. Fibrinogen is a glycoprotein that is critical for formation of platelet plug and is a precursor to fibrin. It is the penultimate step of coagulation cascade. Fibrinogen is synthesized in the liver, and the fibrinogen defect can be quantitative like afibrinogenemia, hypofibrinogenemia, or qualitative like dysfibrinogenemia. The normal value is 180 to 360 mg per deciliter. There are several assays which can be done for fibrinogen, like the Claus assay, PT-derived fibrinogen assay, immunological assay, or gravimetric method to assess fibrinogen. Claus assay is a functional assay which is based upon the time for fibrin clot formation. It's a TT-based assay. PT-derived fibrinogen assay is a fibrinogen-based assay depending on the prothrombin time. Immunological assays are an immunological method which measures fibrinogen antigen rather than the functional fibrinogen, and gravimetric method is based on measurement of the fibrin clot, the weight of the fibrin clot. So the Claus assay is one of the most commonly done assays in the routine laboratory practice. Thrombin is added to an excess dilution, to a 1:10 dilution of patient platelet poor plasma. The time taken for a clot to form is recorded and it is read off a calibration curve to derive the fibrinogen function. So coming to the various permutations and combinations which can happen looking at the screening coagulogram. The first scenario is where you have a normal PT, a normal APTT, a normal TT, normal fibrinogen, and a reduced platelet count. So that is thrombocytopenia. So what do we do next? It is very important to look at the peripheral smear to try and determine the cause for thrombocytopenia. So the most important investigation guiding the diagnostic approach to thrombocytopenia is complete blood count and peripheral smear examination. So the platelet count is measured by the automated analyzers by principle of impedance and fluorescent flow cytometry, and whenever the platelet count is low it has to be cross-checked manually, and as you all know, that is you count 10 fields, oil immersion, multiply each platelet with 15,000. And platelet indices, which are also given by the automated analyzers these days, give a clue towards the platelet function. The indices that are given are platelet crit, mean platelet volume, platelet distribution width, platelet larger cell ratio, and the immature platelet fraction. Now this IPF is coming up a lot, which helps to determine the percentage of immature platelet percentage, and it helps to differentiate between consumptive versus productive reasons of thrombocytopenia. The others, like the MPV, helps determine the size of the platelet, gives a clue towards the presence of large platelets. Similarly, the platelet distribution width again is an indicator for volume variability of platelet size. Right? So the peripheral examination, smear examination, is very, very important in cases of thrombocytopenia. So what are we looking at here? This is platelet clumping. This is platelet cyclidism. Right? Both of these are actually happen are causes of pseudothrombocytopenia or falsely reduced platelet count because of an artifactual EDTA-induced agglutination of the platelets. What you're looking at here is large platelets, almost the size of the RBC. What you see here these are all gray platelets. These platelets have not taken up the normal stain. So this is normal platelet. This is large platelet, which is called as macrothrombocytopenia. One of the most important causes being Werner-Tolute syndrome. This is microthrombocytopenias, tiny platelets seen in Biscott-Aldrich syndrome. This is Dolly body, which is seen in May-Hicklin anomaly. What are the clues that you can get from the RBCs towards which can help you determine the cause of thrombocytopenia? What are you looking at here? These are all schistocytes, fragmented cells. In a peripheral smear where there is thrombocytopenia, you would think of DIC, you would think of a MAHA picture, that is your macroangiopathic hemolytic anemia. What are you seeing here? These are ring forms of Plasmodium falciparum. So again, looking at the RBC here, you are getting a clue towards thrombocytopenia. The cause of thrombocytopenia probably be the malaria infection. So what are the clues that can be picked from the WBCs? Like this is a blast with an RBROC. So this is probably a case of AML which is causing the thrombocytopenia. This is an activated lymphocyte which you may see in viral infections like dengue, which could be the cause for thrombocytopenia in this patient. This is a Pelgrim anomaly, which is commonly seen in myelodysplastic syndrome, another cause of thrombocytopenia. Now, being in Bengal, Harris syndrome deserves a special mention. This is asymptomatic constitutional macrothrombocytopenia, which is mild to moderate thrombocytopenia with giant platelets. The patient has absolutely normal platelet function and does not present with any bleeding symptom, and very, very common in the eastern and the northeastern states. So other tests to evaluate the cause of thrombocytopenia would be liver enzymes, thyroid function tests, B12 and folate levels, HCV, HIV, HPV, a coagulation screen additionally, ANA, and antiglobulin antibodies, lupus inhibitors, medical imaging of course to assess the sizes. So moving on to the next scenario where your screening coagulogram is absolutely normal. So the second scenario where the platelet PT is normal, the APTT is normal, TT is normal, normal fibrinogen and normal platelet count. The next test that you could do is a urea solubility test. If abnormal, consider factor 13 deficiency. If normal, consider evaluating for mild factor defects, mild von Willebrand disease, platelet function disorders, and vascular disorders. And PT or a PFA 100 could be done as a next test to assess if there is any function disorder that we are dealing with. Now bleeding time. Bleeding time in this the process is basically a standard incision is made on the volar aspect of the forearm, and the time the incision bleeds is measured, and that is what gives the bleeding time. Now it is currently becoming obsolete because of certain reasons, like it does not differentiate between vascular causes, function defect, or thrombocytopenia. It doesn't correlate very well with the visceral bleeds, and it is not reproducible. It can have person-to-person errors, and hence is now almost obsolete. So what is done is a platelet function assay, that is your PFA 100, which has replaced the bleeding time. Here, it uses whole blood flow through a capillary device to mimic high shear stress conditions that occur in vivo, that is, said to simulate primary hemostasis. So it gives the endpoint reading where the blood flow through the instrument ceases, that is, the capillary is occluded as a result of the platelet adhesion and subsequent aggregation after exposure to platelet agonists coated on a membrane in a disposable cartridge device. So this is the cartridge device which is coated with platelet agonists, and the whole blood is made to flow through this capillary. And what happens is, since the agonists are present here, the platelets get adhered and activated and aggregated, and it forms a platelet plug which closes the device. So that is called as the closure time. The endpoint is called as the closure time, and that closure time is recorded. So if you are suspecting a platelet function defect, the next test that is usually done is a platelet aggregometry, which is a light transmittance aggregometry, which works with the principle that the light absorbance of platelet-rich plasma decreases and the transmission increases as platelets aggregate. So platelet-rich plasma is stirred within a cuvette incubated at 37 degrees between light source and a detector. Upon addition of various concentrations of panel of agonists, example collagen, ADP, thrombin, ristocetin, or adrenaline, the platelets aggregate and the light transmission increases. So the absorbance changes are monitored on a chart recorder. So a blank tube is also taken where there is no platelet-rich plasma added. And this is the test, that is a platelet-rich plasma is added with a magnetic bar stirrer and an agonist is added. Once the agonist is added, the platelets start to aggregate. So initially the light that is transmitted out is very less. As the platelets aggregate, the plasma starts to become clear and there is a lot of light transmittance. So starting from a light transmittance of 0 degrees, a normal platelet function curve has comes on to a 100% light transmittance, and this is a classic biphasic aggregation curve where initially on the addition of agonists there is a shape change which causes this dip, after which the primary wave of aggregation is seen, and the primary wave of aggregation is seen immediately after addition of the platelet agonists, after which there is a secondary wave that happens because of the release of the nucleotides or the release of the agonists because of the platelet activation. So you add agonists, platelet gets activated, and they also further release agonists from the dense bodies, and that forms a secondary wave. So this is how a normal platelet aggregation curve looks, which is a biphasic aggregation. So again, stressing on the interpretation, all three ADP, collagen, epinephrine normal, ristocetin abnormal, two-thirds Burnett solute, 1 villiprin. How do you differentiate? Add 1 villiprin factor. If there is a aggregation, platelet aggregation after that, then consider 1 villiprin disease. If there is still no aggregation, then it is Burnett solute. If all ADP, collagen, epinephrine, there is no aggregation, then the cause is Glasmann's thrombocythemia because there is defect in 2B3A itself. So there will not be any aggregation even though there is agonist being added. If the primary wave is formed but the secondary wave is not formed, then you consider storage pool defect or thromboxane A2 deficiency. In both of these conditions, in the collagen, when collagen is added, there will not be any primary or secondary wave. Another test that can be done for platelet function defects is a flow cytometry. Now, if thrombosthenia or Burnett-Solid syndrome is suspected, an analysis of the membrane glycoproteins can be done most conveniently by flow cytometry. So, if you look at this flow cytometry graphs here, the platelet is actually identified by CD42B antibody, and it is marked in red. Now, if you look at the expression of CD41 and CD61 in these uh, platelet population, you can see that there is no cells in the double positive region, no cells in the CD41 positive region or in the CD61 positive region, which means that these platelets are actually double negative for CD41 as well as CD61. So that is, there is a lack of the GP2B3A receptor, and the diagnosis here would be Glanzmann's thrombosthenia. So moving on to the next test, that is a urea clot solubility test, which is a screening test for uh, factor 13 deficiency. Lack of cross-linking of the fibrin polymer due to lack of factor 13 makes the fibrin clot soluble. So basically this fibrin polymer that is present before the activity of factor 13 is a soluble clot. After factor 13 is added, it becomes a cross-linked fibrin clot which is insoluble. Now, if there is a defect in factor 13, then the fibrin clot is unstable and it would dissolve in 1% monochloroacetic acid or 5 mole urea solution. And this is a screening test for factor 13 deficiency. So moving on to the next scenarios where either the PT is abnormal or the APTT is abnormal or both the PT and APTT is abnormal. So the third scenario, with an isolated APTT prolongation with normal PT, TT, fibrinogen and platelet count, the next thing to do would be repeat the APTT with a 50-50 mix. What does that mean? We take equal volumes of the patient sample and equal volumes of control plasma and do an APTT again. If the APTT becomes normal, that is the APTT corrects, then we would test for factor deficiencies, isolated deficiency of factors of the intrinsic pathway like factor 8, 9, 11, or mild deficiencies of the common pathway like 2, 5 or 10 deficiency. If the 50-50 mix is abnormal, then we'll have to look for inhibitors to specific factors like factor 8, 9 and 11 or non-specific like antiphospholipid antibody or the AMPA. So what is the next test? We would do is an inhibitor screen in this scenario, or if we are suspecting factor deficiency, the next test would be to do a factor assay. Similarly, the next scenario where there is an isolated abnormal PT, but there is normal APTT, normal TT, normal fibrinogen and normal platelet count. Again, repeat a 50-50 mix. If the 50-50 mix is normal, test for factor deficiency of the extrinsic pathway like factor 7 deficiency, or sometimes it could be other multiple factor deficiencies like liver disease, vitamin K deficiency, warfarin therapy, or it could be mild factor 2, 5 or 10 deficiency. And if the 50-50 mix is abnormal, then again suspect inhibitors specific to factor 7 or non-specific like APLA. So if we are suspecting inhibitor, the next test would be an inhibitor screen. If we are suspecting factor deficiency, the next thing to do would be a factor assay. And the fifth scenario where both the PT and APTT are abnormal, but your TT fibrinogen and platelet count is normal. Again, we will do a 50-50 mix. If it corrects, then we are talking about factors of the common pathway like factor 5, 10 and prothrombin, or multiple factor deficiencies like for instance factor 5 and 8 are a combination that is common, or it could be liver disease, vitamin K deficiency or warfarin. If the 50-50 mix is abnormal, then we have to test for inhibitors to specific factors of the common pathway like factor 5, 10, prothrombin, or non-specific inhibitors like APLA. Again, inhibitor screen if you are thinking of the inhibitor activity, and factor assay if you are thinking of factor deficiency. So what is this mixing study? It is done to distinguish factor deficiency from factor inhibitors like lupus anticoagulant or specific factor inhibitors. It is with the concept or the principle that the factor levels that are 50% of normal should be able to give us a normal PT and APTT. So the patient plasma is mixed in a 1:1 ratio with pooled normal plasma that has 100% of normal factor levels, resulting in a level of 50% at least in the mixture. So correcting with mixing would mean factor deficiency, and failure to correct would mean that there is an inhibitor which is also inhibiting this normal 50% that is present in the pool normal plasma. So let us just see it with the illustration. So this is a normal person who has all the factors, right? His PT and APTT are normal. This is a case of hemophilia which has a factor 8 deficiency. So this patient's APTT is abnormal. Now if I take 1:1 mix of each of the uh, equal parts of the normal plasma from the normal individual and from this hemophiliac and mix it. So half patient with half control. So this factor 8 that was present in the normal individual will actually now correct the APTT in the patient who had factor 8 deficiency. So his APTT that time was 76, but after mixing it with the normal control plasma, the 50-50 mix has brought the APTT now to 32, which is normal, right? So this is corrected because of mixing, and which means that it is because of deficiency of the certain factor. In this case we are talking factor 8. So how do we determine that it has corrected? So there should be at least more than 50% correction of the increase time, or it should be 2 seconds of the upper limit of normal range. There are certain formulas like the Chang formula which is used to determine correction. So the percentage correction is calculated by patient's APTT minus the 1:1 mix APTT divided by the patient APTT minus the normal pool plasma's APTT into 100. So for instance, uh, they have given an example over here, and if the factor value comes more than 75%, then we consider factor deficiency, and if the value comes less than 75%, then we are suspecting inhibitors. Similarly, there is Rosner's index also, which is used to calculate correction. So the 1:1 mix APTT minus the normal APTT divided by the patient APTT into 100. A value more than 11 would mean there is inhibitor, more than equal to 11 inhibitor, less than 11 would mean that it is corrected and it is a factor deficiency. So the next thing to do after a mixing study is a correction study. So in a case where the APTT is prolonged, we do a mixing study and we realize that the APTT has corrected. So we know now that it is a factor deficiency. Then how do we determine that which factor is deficient? For that we do a correction study. Initially it used to be done with a serum and adsorbed plasma. Now we take factor deficient plasma to do the same. For instance, if I take factor 8 deficient plasma and mix it with the patient plasma and do an APTT, and the APTT does not correct, that means there is no factor 8 in this patient because we have used 8 deficient plasma and we've mixed it with a patient who does not have factor 8 itself. So the APTT has not gotten corrected. Now if we take factor 9 deficient plasma, mix it with the patient plasma and the APTT corrects. So what does that mean? Though we have taken factor 9 deficient plasma, the patient has factor 9. So he is able to correct the factor 9 deficiency and APTT is getting corrected. So the factor 9 in this patient is normal. So the problem here was factor 8 deficiency. After which we would do a factor 8 assay. That will be the next step with respect to the testing for factors. So coagulation factor assay is done when the screening tests indicate that an individual has a coagulation defect. The plasma concentration of the coagulation factor has to be assayed. Such assays establish the diagnosis of the deficiency or the defect, assess its severity, and they can also be used to monitor replacement therapy and to detect the carrier state in affected families. There are two types of assays, the one-stage assay versus the two-stage chromogenic assay. The one-stage assay is done for factor VIII activity, is a modification of the APTT assay that is used for routine diagnosis. It is the time to clot formation and is dependent on the quantity of factor VIII. Whereas the two-stage chromogenic assay is done in two steps, where the first step is to generate factor A, and it actually measures the role of factor 8 as a cofactor to generate factor 10, and then the uh, factor 10 is determined in the second step by a chromogenic substrate which gives a color formation. So it is the one step assay is a clot based assay, whereas the two step assay is a chromogenic assay. So the next scenario is if the mixing study does not correct the PT or APTT at all, then what you will have to suspect is the role of inhibitors. Now, circulating anticoagulants or acquired inhibitors of coagulation factor are immunoglobulins that arise in congenitally deficient individuals as a result of the administration of the missing factor or in previously hemostatic normal subjects as a part of an autoimmune process. So the inhibitor is suspected when a prolonged clotting screen does not correct even after mixing, and circulating anticoagulants or inhibitors affecting the APTT may act immediately or it may be time dependent. So the test that we would do for that is an inhibitor screen. So to detect both type of inhibitors, normal plasma and the test plasma are tested immediately after mixing and also after incubation together at 37 degrees for 120 minutes. So tube A is your patient plasma, tube B is the control plasma, tube C is a mixture of both. So tube A is incubated, B is incubated separately, tube C is also incubated separately, and tube D is nothing but a mixture of tube A and B that is done after the incubation. So if in the fresh or the immediate mix, which is done after 0, 1 hour and 2 hour, and the incubated mix again done at baseline after 1 hour and 2 hours, if the immediate mix is prolonged, then we are talking about immediate acting inhibitors like factor 9 inhibitor or lupus inhibitor. Or if the incubated mix is more prolonged than the immediate, then we are talking about late acting inhibitors like factor 8 inhibitors. So the difference between the fresh mix and the incubated mix is important, and if the time is between 8 to 12 seconds, we are talking about factor 8 inhibitors, which are time dependent inhibitors. If the time is less than 8 seconds, then we are talking about other inhibitors or probably lack. So the inhibitor screen is to determine the presence of inhibitors in the first place and is also to differentiate between immediate acting and late acting inhibitors. Then comes the quantification of the inhibitors, which is done by the Bethesda assay and it's reported in Bethesda units. So basically diluted patient plasma and pooled normal plasma is mixed and incubated for 120 minutes, and the residual factor VIII activity is measured at each dilution, and the residual activity that is present, the Bethesda titer is derived from a standard graph and corrected for the plasma dilution. So coming to the next scenario where PT, APTT, TT all are prolonged, fibrinogen is reduced, then what are the possibilities that we have to think about? So if the PT is abnormal, APTT is abnormal, TT is abnormal, and fibrinogen is reduced, first scenario where the platelet count is also reduced, then we have to think of DIC or acute liver failure. Or the other scenario where all of this is abnormal but the platelet count is normal, then we have to think of fibrinogen defect or liver disease. So the next test, relevant test that can be done can be of FTP or D-dimer. So this is the ISTH DIC scoring system, which is used to determine if there is presence of DIC, which includes platelet count, D-dimer, prothrombin time, and fibrinogen levels. A score of less than 5 is suggestive of non-overt or low-grade DIC, which should be repeated in 1 or 2 days. and a score of more than 5 gives a laboratory evidence consistent with over DIC, and this has to be done daily. So a little bit as to what is the difference between FTP and D-dimer. So when the fibrinogen is converted to fibrin, this non-cross-linked fibrin, if broken down by plasmin, forms the fibrin degraded products, that is your FTP. Whereas after the activity of factor 13, if the fibrin, the cross-linked fibrin that is formed, when the plasmin acts on that, the products that are formed are called as D-dimer. So there are several assays done for D-dimer, of which the latex agglutination assay is one of the common ones, where latex bead with anti-D-dimer antibodies added to the blood, and if there is presence of D-dimer, then it forms agglutination. So to summarize all the scenarios that we saw so far, the first scenario where the entire screening coagulogram is normal, the patient is still bleeding, then consider platelet function abnormality, factor 13 deficiency, vascular disorder, or mild factor deficiencies. Next, the scenario where the platelet count alone is reduced, everything else is normal, then the bleeding is probably due to thrombocytopenia. Evaluate for the cause of thrombocytopenia. You could do a peripheral smear examination, which would give you a clue. The next scenario where there is isolated PT prolongation with everything else being normal, consider a factor deficiency of the extrinsic pathway like your factor 7 deficiency, oral anticoagulant, mild liver impairment or vitamin K deficiency, lack with some reagents, and mild factor 2, 5 or 10 deficiency, which are factors of the common pathway. The next scenario is where your APTT alone is abnormal, everything else is normal. So isolated APTT prolongation causes would be factor 12 deficiency, 11 deficiency, 8 deficiency, 9 deficiency, procalcitonin, and high molecular weight kininogen deficiency. So here also, if the patient is bleeding or non-bleeding, can give us a clue as to which factor we're talking about. If the patient is not bleeding, then factor 12, PK and HMWK are the causes. Circulating anticoagulants like lupus, von Willebrand disease, mild factor 2, 5 or 10 deficiency are other conditions. Next scenario where the platelet count is normal, the TT fibrinogen are normal, but there is elevation of both the PT and the APTT. Then we have to think of the factors of the common pathway like factor 10, 5, 2 deficiency, vitamin K deficiency, or multiple factor deficiencies like liver disease. The other scenario with an increased PT, APTT, TT with a low fibrinogen, if the platelet count is also reduced, consider defects like DIC. If the platelet count is normal, then fibrinogen deficiency is to be thought of. And the final scenario where there is an increased APTT along with an increased TT, usually very markedly raised values, then heparin contamination is the most important cause. So to summarize, a good detailed comprehensive history and clinical examination is the best predictor of a bleeding problem. The baseline screening test should be ordered before appropriate specialized tests are suggested. There must be a logical systematic approach and a discriminate use of the laboratory investigations to reach the diagnosis and to assess severity. A simple approach to detect the cause is to look at the hemostatic system into 3 compartments, that is the blood vessel, the platelets, and the coagulation proteins. Thank you very much for your patient listening.